Hi, I'm Dr. Jared Gardner, and today we're going to talk about something that's a little bit controversial, keratoacanthoma. The reason it's controversial is some people believe these are a benign hair follicle related tumor that goes away on its own and maybe doesn't need more treatment. Other people believe that it's a variant of squamous cell carcinoma. So if you haven't watched my video about squamous cell carcinoma and actinic keratosis yet, that might be helpful for you before going into this video. I'll put a link in the video description down below. So I was trained that these are a variant of squamous cell carcinoma, but I've heard convincing data and arguments to the contrary, and I'll talk more about that as we go through the video and look at some cases. But the main idea is that these lesions arise usually either on the face or the extremities of elderly, light-skinned patients, usually who have had a lot of sun exposure, and they arise as a little bump that grows rapidly and has kind of a crater filled with keratin in the center. I'll show you a picture in a minute. And then this arises over a period of a few weeks to a month, and then the tumor begins to regress spontaneously, and within 4 to 6 months goes away completely. So that's the classic story. And if you have a case where you have the classic story and it looks classic clinically and microscopically looks classic, then it makes sense to say, oh, it's a keratoacanthoma and it's benign. The problem is that usually one part of that is missing, in my practice at least. Either I can't see the entire lesion, or it doesn't have perfect histologic features, or I don't have the full clinical story. And so I've always struggled with knowing what to call these because I don't know for sure how to figure out which ones will go away and which ones will stay. So let's go into the details, look at some clinical pictures, and talk about what we see microscopically, and then you can decide how you want to handle these in your practice. Okay, so here's an example of the clinical image of keratoacanthoma, a very nice picture from Wikipedia. And you can see it's a dome-shaped papule, which will eventually progress into a nodule, and it's got a smooth surface and then this hole in the middle, a crater, and almost looks a little bit like the umbilicated papule of molluscum. And I think there was actually in the olden days a name that was similar to molluscum for this entity, but I don't think we use that anymore. In any case, this crater in the middle often gets filled with keratin debris, which can kind of erupt out of the surface like a volcano. Here's a really good example of a much larger nodular one that has the hole in the center filled with a mound of keratin debris, and this is a very nice, beautiful image from the McKee Pathology of the Skin 5th edition, which is a wonderful dermpath textbook. It's my go-to dermpath book I use in my practice, and I'll actually have a video review of that textbook hopefully up on my channel soon, and I'll put a link down below and also a link to where you can buy this book if you like it. So thanks so much to Elsevier for letting me use this image. But you can see the keratin-filled crater. So the reason it looks like this clinically is because this is how it looks microscopically, and these are images from my own textbook, The Survival Guide to Dermatopathology, and this is really an introductory level book that's aimed at trainees and also at general pathologists, non-dermatopathologists who deal with skin in their practice. So totally shameless self-promotion of my book here. I do have a conflict of interest, obviously. I wrote the book, so I kind of like it, and I will receive royalties if you buy it. So you've been forewarned. But anyway, I think that these images show very nicely the reason that you see the clinical appearance. You've got this mound of keratin erupting out of the surface, kind of shaped like a volcano, and then pushing down into the dermis is this cup-shaped kind of protrusion or invagination of very glassy pink keratinocytes with abundant cytoplasm. You can tell how pink and glassy they are even from low power. If you cut right through the middle of the lesion, you'll see this crater. But just like all things that have kind of an invaginated cystic shape, if you cut just to the side of the lesion when you're sectioning it grossly before submitting it for histology processing, if you cut it to the side of the center, it will look like a cyst, and you won't necessarily see the connection with the surface. So you always have to think in 3 dimensions in dermatopathology, and particularly with these umbilicated kind of papules like molluscum or like keratoacanthoma. Both of these views are possible depending on what level you section through the lesion. And again, down here you can see keratin debris in the middle. It's got a cystic protrusion, and it's made of bright keratinocytes with abundant pink cytoplasm. Okay, let's look at some other examples here. of keratoacanthoma. Here's a really nice classic one. You can see it's cup-shaped, it pushes down, it's got that kind of open crater at the top filled with keratin debris. And it's when it's a nice big shave like this, and I can see all the way under the lesion, and I can see that I'm exactly what I'm dealing with, the base of the lesion's visible, then it's less worrisome for me to say, okay, keratoacanthoma. But even so, in my community, most of the derms that I work with, they think of these as a variant of squam and tend to treat them like that. So I think they still usually prefer me to call it squamous cell carcinoma, keratoacanthoma type. But again, I've heard some good arguments from people that, if this were, say, on the lip or on the nose or the eyelid or the finger, and you're in a situation where you're dealing with a big surgery that might actually cause morbidity to the patient, that maybe it's reasonable in those cases, if you really think it could be a keratoacanthoma, to have a discussion with the treating physician and with the patient to maybe consider some more conservative alternative options rather than aggressive surgery. So I do think that I've heard from really good experts in dermpath who have presented cases at meetings that have kind of changed the way I think about this and made me realize that there may be a time and a place to be more conservative. The problem is that in general, I just don't know for sure when one's going to behave like a keratoacanthoma is supposed to and regress on its own, and when they're going to actually be more aggressive. In a case like this, where we're on probably the dorsal arm, I can see the base, I'm not worried about this lesion. Whatever name you call it, I think it's going to be fine. You can see that these islands of keratinocytes, they look quite like a well-differentiated squamous cell carcinoma to me. And they're very glassy. They've got that abundant, really smooth, homogenized, or what we call glassy, pink cytoplasm that's filled with keratin, a little bit of atypia, but nothing terribly striking. And sometimes the cells can be quite bland. In fact, I mean, there's a little basal layer atypia out here and some mitotic activity, but that's if I start seeing really wild, super ugly cells or really infiltrative growth, I tend to get scared to call those squamous cell carcinoma, keratoacanthoma type, because I'm worried they'll behave aggressively. That said, there have been reports of keratoacanthomas that have had perineural invasion and things like that that are aggressive features usually, and yet still behaved indolently clinically. So that's why this has been such a controversial entity, is that there have been publications that show support for both sides, both for saying it's benign and it'll regress on its own, and other sides saying no, it can be bad and can behave aggressively sometimes, and it should be treated. So you can review the literature, and the McKee Derm book that I mentioned earlier has a real nice section on this, so you can check out and see some links to publications that go on both sides of the spectrum. All right, look at more examples now. Here's another one with a nice crater shape, and it's cystic, and there's a lot of inflammation under it. Again, it's got that glassy, abundant pink cytoplasm. And there's another view of it. So again, it looks different on each piece of tissue because of the way it's sectioned. Here's a really big one that I can't, even with a 2x objective, I can barely fit on the screen. You can see just a little opening to the volcanic crater up here. I guess you can't see the arrow very well because I've got the light turned up. But in the top, you can see that. And then here it's got more of a cystic shape, and it's just a massive amount of keratin in there. And the base, again, islands of glassy keratinocytes pushing downwards. Really nice example. And even if the margin, I guess the deep is focally positive here, but you really get a sense that you can see that the lesion kind of has a smooth border, and you can see what it looks like. And again, there are some nice publications out there about what the criteria should be microscopically for keratoacanthoma, and I still, again, this is an area that my views are still evolving, and I still don't have a really good concept for knowing when it's okay to say keratoacanthoma type versus just squamous cell carcinoma invasive. So this is an area that even 7.5 years into practice, I'm still kind of learning more about it, and my views are evolving and changing from the way I was trained, but I still have retained some of those original views. So probably in a couple years, I'll look at this video and say, rubbish, I totally believe differently now. And I suppose in a way way, that's scary, but that's also part of medicine that's good, that we should continue to challenge what we believe and think about things differently and let our views evolve. I don't want to be static and just learn one thing and then never change, because medicine's changing. It's science. It's dynamic. So there's our philosophy lesson for the day. Here's a great example of one that looks cystic. All right. Again, it's because of the angle of cut, because let's see, where is there? Actually, you can't really see the connection in the angle or in the sections that we have here. But to me, it's a really good example of how cystic they can look. And this is why I'm cautious about calling stuff epidermal inclusion cyst or follicular infundibular cyst when it's a cyst that's really big and very superficial or connects to the surface on the dorsal forearm, dorsal hand, sun damaged extremity. Because a lot of times if I just see a superficial cyst that's right up close to the surface, and look at the lining, it looks like a cyst lining. It's very bland. There's really no atypia. It does have parakeratosis inside instead of ortho. It has the nuclei retained, and it lacks a granular layer. So you could say that's one point towards it being something a little more atypical than a regular cyst. But really, it doesn't look terribly worrisome. But then here, when you see the rest of the lesion, clearly this thing is not a regular cyst. It's too complex at the bottom. It pushes down too far, has too many keratinocyte nests that bud out from the outside of it. So anytime I see what looks like a cyst but is really big, or it's complex, or it connects to the surface, and it's particularly, I'm worried about this on the dorsal hand and dorsal forearm, I'm always cautious, and I'll say something like it's a cystic squamous proliferation, and it's possible it's a cyst, but I can't exclude a cystic squame or a squame keratoacanthoma type that's just superficially biopsied, because I see that scenario happen a lot in my practice. And here's what I'm talking about. Here's another example. You can see, look, it looks kind of like a cyst in some areas. If you just had that, you might think, oh, that could be a cyst. But it's way too complex. Cysts should have one lumen. Maybe when they rupture, sometimes they can get a little more complex. But to me, this is way too complex. So even if it's incredibly bland and really even if it lacks some of the glassiness, if I see a cystic thing on an older sun-damaged person and it's real complex like this, I'll call it squamous cell carcinoma or squame keratoacanthoma type rather than a cyst. Again, whatever terminology you use, I think the take-home point is don't just call something like this a cyst. And I see people struggle with that in practice, and I see that happen on a regular basis where someone thinks it's a cyst and it's actually either a squamous cell carcinoma or keratoacanthoma. Let's see if I can get this in the screen here. These lesions are often so big it's hard to fit them on the screen. What a beautiful example of that keratin-filled crater erupting out of the surface, and you can see it's just got this nice kind of radial arrangement here where each little island has a zone of keratin in it. It's quite beautiful microscopically, and you can see kind of a smooth border there. Can't really see the base there, but you would imagine that this probably doesn't go too much deeper than what we have here. Kind of if you extrapolate what you think might happen under the biopsy, which is a little dangerous business sometimes because you can't always tell what's happening deeper. Again, the glassy cells, so another nice example. But the reason I'm showing this one is look at this next one. Kind of a similar low power configuration with the crater, the keratin. It's erupting like a volcano. In some parts of the tumor, the cells look a lot like what I showed you before. Maybe a touch more atypical, but there are certainly glassy cells with abundant cytoplasm. But let's go over to the other side and take a look what happens over here. The tumor is clearly has areas that look like poorly differentiated squamous cell carcinoma. Ugly, nasty epithelioid and even spindled cells. And as you go down deeper, definitely all this stuff is all positive for keratin and P63. Spindle cell squamous cell carcinoma. This is poorly differentiated squame. But at the top of the lesion, it looks so much like a keratoacanthoma. So this is cases like this where I've seen really aggressive looking features, nasty looking features, or poorly differentiated carcinoma down below what otherwise at the surface looked a lot like a keratoacanthoma. See all that stuff? This is spindle cell, poorly diff squamous cell carcinoma right in here. All right? That's not regression change. All of that stained, or many of those cells stained positive for keratin and P63 or P40. I can't remember which one we used. the reason is that this is why I'm cautious, particularly if I can't see the base of the lesion, about just saying, oh, keratoacanthoma, because I know that there are some dermatologists who really are very conservative and say, oh, it's keratoacanthoma, we don't need to do anything else, or they do only minimal treatment. And I always worry that what if we have one of these lesions, if we can't see the base, what if we have something more aggressive down below, and if the patient doesn't get adequate treatment, that could be problematic for them. So again, take all of this, do your own reading, and decide what you believe, and see what you think. But those are the kinds of cases that make me a little bit concerned. All right, now more of the same, and by now you're like, okay, we got it. We've seen enough cases. Well, if you're a resident, all you want is you need to pass the boards, right? So you need to take the knowledge and go home. If you're in practice deciding what to call stuff and the patients are going to get treated based on what you say, then you want to see as many examples as possible. When you open a book and there's like 2 pictures there, and you're like, oh, can it look like this though? At least that's what I think when I'm in practice. I want to see as many pictures as possible. Okay, so the reason I'm showing this one though is, look, this looks great for keratoacanthoma, and it's got a lot of inflammation under. All that blue stuff is inflammation. Look at the periphery of the lesion here in an extra cut. The lesion looks totally different. It's become very thin and atrophic lining, very much like a cyst. If you just had this, you might think, oh, it's a cyst. And again, that's where I caution, if you see something that looks like a cyst, but it connects broadly with the surface and it's in sun damaged extremity, or the lower leg also, even if there's not a ton of sun damage, that's when I think this is probably actually not a cyst, but a keratoacanthoma, because I've seen many cases where you can see clearly it's keratoacanthoma, or again, full-blown squamous cell carcinoma, whatever. But then it has areas like this. And so what's happened here is that the lesion has started to undergo regression. So this probably is a real keratoacanthoma that is doing what it's supposed to do. It's being attacked by the immune system and is beginning to regress away. So I'm going to show you a few examples of what that regression looks like. A regression, often the lining of the cystic spaces in the keratoacanthoma get thin and atrophic. They tend to have less cytoplasm sometimes. And they'll often, let's see if I can get the light right, they'll often begin to pick up a granular layer. So they really will look even more like a regular cyst because they won't be very atypical. They may not have as much of that glassy expansile cytoplasm. They have a granular layer. They may just have orthokeratin or mostly orthokeratin that's even loose and flaky. I mean, if I told you this was part of a cyst, anyone would believe that. You could say, yeah, of course, that's a follicular infundibular cyst, or if you like, epidermal inclusion cyst, as some people call them. But that's what you would think, but then clearly it's not. It's clearly part of this lesion here. So beware the cystic proliferations in sun-damaged skin, especially when you can't see the whole lesion. And they often, when they begin to regress, they usually have inflammation and or a zone of fibrosis underneath them. That's kind of evidence of the regressing process. So when I see ones like that, I'll say squamous cell carcinoma, keratoacanthoma type with features of regression, or something like that. And you can use, again, whatever language you want. Here's another one that is regressing, and it looks very much like a cyst, but it's way too complex. It's too complex, too many different cystic spaces, not just one cystic space. It's broadly opening up to the surface and has a cup shape. And here it really looks like a cyst, but again, a little bit too complicated and too complex at the bottom. This is a good example, though, of underneath the lesion, there's a broad band of fibrosis. Here's their normal dermis, normal for this person. It's loaded with solar elastosis. All the collagen's replaced by that gray-blue solar elastosis. And then over here, it disappears. And what you have is this zone of fibrosis, spindle cells, collagen, a few giant cells in this case right there, multinucleated giant cells, and inflammation. Lymphocytes mostly, sometimes histiocytes. So that's sorry, I dropped the slide into the scope. That's an example of a regressing keratoacanthoma. And again, whatever name you call it, this lesion clearly looks like it's treated, right? It's a big, deep, broad shave excision. You can see that it's clearly negative at the margins, and whatever name you're giving this, this is an adequately treated lesion in my opinion. Here's just one more example of part of the lesion that looks like a cyst. And then in this cut, you can see it clearly opens up to the surface and makes a cup shaped, but it's underneath it. It's got a bunch of scar-like fibrosis, very much scar-like in this case. And the lining is beginning to look like a cyst too. It's getting the granular layer back. It's got the loose, flaky orthokeratin inside. It's lost that abundant, expansile, glassy cytoplasm. And again, look at that nice, beautiful scar right underneath it. So to me, this is very characteristic of a regressing keratoacanthoma. This cup-shaped cystic lesion with a big zone of scar and some inflammation underneath. And just like in any keratinocytic proliferation, whether it be squamous cell carcinoma, actinic keratosis, seborrheic keratosis, keratoacanthoma, when you get inflammation, the inflammation can produce a lichenoid interface reaction pattern, and you can have dying keratinocytes. I don't know if we have any in this particular field, but you can have vacuolar interface change and dying keratinocytes in the lesion. So if you see lichenoid change under these, don't be surprised at all. That can happen to pretty much any keratinocytic lesion that becomes inflamed. And one more example of the same thing, showing just how thin and atrophic the lining can be. It can get so thin that it's only a couple layers thick. So I feel like I often have trouble convincing my trainees, my residents, that these are actually keratoacanthoma or a regressing keratoacanthoma or squamous cell carcinoma because they say, look, it doesn't look atypical at all. It's so thin, it looks like a cyst. But it's because I've seen plenty of them where you have the whole lesion out and clearly it shows areas that look like keratoacanthoma in the other aspects of the lesion. But this is kind of the end stage as it's totally regressing away. It's just left behind a big blob of keratin here, the eruption of the volcano of keratin, and very, very little of the lining left. It's almost completely atrophied away because of the immune system. So I hope that gives you a little overview of keratoacanthoma and the range of features that you can see and some of the controversy surrounding it. And again, I encourage you, as with any topic in medicine, learn from your mentors, learn from different mentors who have different views, and then go search the literature yourself and read yourself and decide what you think and what you're sure about and what you're not sure about. And then as you begin to practice and build up experience with cases, you can make further decisions and let your views evolve over time. That's the way I try to practice medicine and the way I try to learn, and I hope that you'll be inspired to do the same. Thanks so much for watching. If you like this video, please click like. Feel free to share your comments or your views on this quote controversy in the comments down below. I'm always happy to learn more, and in fact I've learned a lot about this from watching other experts discuss this very issue on Twitter and other social media platforms, and from following those discussions, that's how I began to actually have a more open mind and change my views about this area. And if you haven't yet, please subscribe to my channel. Thanks so much for watching.